Guys, welcome back to another session of this lecture series. And today is Wednesday. So what's about Wednesday? Nothing great, just an ordinary day. Okay, jokes apart. So today we will be looking at something on atropine and its substitutes. Now, as you know, atropine is an anticholinergic drug, but you see atropine substitutes being used in medicine to a greater extent than what you use atropine. And so I thought maybe it's a good way to start up with case-based discussion on use of atropine and its substitutes in clinical practice. So here it goes. So case 1. So here we have a 60-year-old man who is brought to the casualty. Now we call it as casualty here in Asia. Some people call it as emergency medicine and so on, ER, whatever it might be. It's a place where people are brought in emergency. That's what I mean by casualty. In unconscious state, he has excessive frothing at his mouth. On examination, he has pinpoint pupils which are sluggishly reactive to light. He has a pulse rate of around 59 beats per minute, a respiratory rate of 13 per minute. He has a blood pressure standing as 100 by 70 millimeters of mercury. He has bronchial wheezing, which is heard or auscultation, and they also noted that he had 2 episodes of diarrhea before he was brought to the casualty. He also complained of nausea and vomiting when he was conscious. He had excessive sweating, runny nose, excessive lacrimation, and that was being told to us by his relatives. On the next day of admission, he had 1 seizure attack, and his wife has given a history of intake of malathion, that's organophosphorus poison. Okay, so that's a case about a person who has been brought with so many complaints, and then we come across a word called as malathion. So what is malathion? Malathion is an organophosphorus compound, okay, and it's an irreversible cholinesterase drug. Now if you are new to my channel, you may watch my video on organophosphorus compounds, where I have given everything that deals with its compounds, what cholinesterase stands for, how does it help in increasing acetylcholine levels, and so on. But to be very brief, just note that it's an irreversible anticholinesterase drug. So what do you mean by anticholinesterases? Cholinesterases are the enzymes which will lysed up the acetylcholine within few milliseconds. So drug which will inhibit this anticholinesterase will indirectly increase acetylcholine, because there would be no enzyme which can degrade acetylcholine in that condition. So the levels of acetylcholine increase at the synaptic level. So this scenario, what you have come across, pinpoint pupils, bradycardia, frothing, excessive of secretions like sweating, runny nose, lacrimation, diarrhea, bronchial wheezing due to bronchial secretion, these are all nothing but effects of excessive acetylcholine present in the body, which is not getting degraded. So these things, these symptoms and signs can also be remembered as the effects of acetylcholine on the body. So that's one way or the other of remembering things. Now if that's the thing, the next thing that was done for this patient is he was given atropine. What is atropine? Atropine is a anticholinergic drug. So atropine counteracts this excess acetylcholine, this excess cholinergic parasympathetic activity. This enhanced parasympathetic activity is counteracted by atropine by inhibiting muscarinic receptors. Now atropine to extent only acts on muscarinic receptors, all muscarinic receptors, but then the synthetic congeners may also have action on the nicotinic receptors. So But basically atropine is an anticholinergic drug. It's also called as anti-muscarinic drug, okay, whatever it might be. So it's an anticholinergic drug which is given to this patient in IV bolus form in a dose of around 2.2 to 5 milligrams every 10 minutes to a maximum of around 200 milligrams. So you need to continuously give atropine till all the signs of atropinization are achieved. Again, if you are new to my channel, you need to watch my video on organophosphorus poisoning, where I have described this in much more detail. At a later stage, atropine is given in the drip form, and the dose is mentioned here is 0.02 to 0.08 milligrams per kg. IV drip has to be given for roughly 3 to 5 days after the intake of poison and the patient getting admitted to the hospital. So in short, atropine is an anticholinergic drug and competitively inhibits all muscarinic receptors. Atropine only crosses blood-brain barrier at high doses. There is another form, another isomer, not isomer I should say, another drug in the same group which can cross the blood-brain barrier. But anyway, we are not dealing with that. We just deal with atropine at this moment. So it will cause atropine effects on the CNS only if you give very high doses of atropine to an individual. So what atropine will be supposed to cause? Atropine is an anticholinergic drug, so it will block all the actions of acetylcholine. So everything that you saw in organophosphate poisoning, that exactly all the things will be reversed. So the patient will have blurred vision. Now that's basically due to dilatation of the pupils. Decreased salivation, that's because the secretions dries up after giving atropine. Difficulty in swallowing and dryness of mouth and nose are also due to less of secretions. Decreased sweating, this decreased sweating can also lead to fever in patients. Now you can see that you give atropine in larger doses in patients with organophosphorus poisoning, so you can see a kind of picture where the CNS is excited. So delirium, excitement, nervousness, hallucinations, headache, these all things will come up after giving atropine to a patient in high doses. So that's what is happening, exactly the reverse of acetylcholine. Then it can also lead to dry skin, that's because of less sweating, loss of taste sensation, nausea, vomiting in general, irregular and fast heartbeat. Now that's important. Acetylcholine causes bradycardia, atropine will cause the reverse of that, that is fast heartbeat. It can cause difficulty in urination due to dilatation. In fact, this effect of atropine is used in therapeutics also. It can lead to rash and constipation, which is again rash related to drug, but constipation is opposite to what will occur with acetylcholine and what has been described in the case. So that is what happens when you give atropine. So exactly the reverse of acetylcholine. But sometimes atropine can lead to severe allergic reactions, atropine administration. So in those cases you will see a kind of anaphylactic reaction coming up. Now if you don't want to remember all the effects of this, there is one sludge syndrome. Now that's not something from my side, that's everybody knows about it. So sludge syndrome refers to effects of atropine. So that is excess of salivation, lacrimation, urination, diaphoresis, enhanced gastrointestinal, reduced gastrointestinal motility, and emesis. So that is what happens with the patients who take atropine. So that's other way of remembering things if you are familiar with mnemonics. But anyway, if you don't want to go through those all things, just try to remember this case, and exactly reverse of that what happens is with atropine. So atropine is a drug of choice antidote for organophosphorus poisoning. Now if that's very clear, let's move to the next case related to use of atropine in clinical therapeutics. Now here is a 53-year-old man who presents with syncope and dizziness. Okay, so he has a kind of fainting attack, so kind of a thing, and lightheadedness maybe. He is a known case of myocardial infarction, that is heart attack, so around 3 years back, and he is on appropriate treatment for that. So he is taking treatment for whatever condition he has, whatever cardiovascular condition he has. Anyway, it's a customary to take a routine ECG of all the patients of that age who have syncope or dizziness, lightheadedness, keeping in mind CVS issues. So ECG was recorded routinely, and it was diagnosed that the patient has a type 1 second degree heart block. Type 1 second degree heart block. Okay. No recent ischemic changes were observed on the heart. Now that's also important, right? Because you don't want to get misled by what's happening. So there is no ischemic changes. So it appears to be that this is due to type 1 second degree heart block symptoms. Definitely, if there is any kind of conduction problem within the heart, atropine will try to enhance the conduction. It will help the heart to come out of the conduction defect, the blocks, as well as bradycardia. So atropine increases heart rate, and therefore it can increase the perfusion within the body. Atropine is one of the drug of choice, I should say, for heart blocks which are symptomatic, but which usually are till type 1 second degree heart blocks. For type 2 second degree heart blocks and type 3, which is kind of complete heart block, usually atropine is not given because it may not be of any help to those individuals. But symptomatic, I should say, heart blocks, maybe type 1 in those cases, or type or second degree with type 1, you can give atropine as a drug of choice. Atropine should be used as a bolus dose of 0.5 milligram, and then standard recommendation is to repeat a dose of 0.5 milligrams every 3 to 5 minutes as needed till the total dose does not exceed 3 milligrams. So you can repeat if you want, but you want to achieve a required heart rate, because atropine will cause tachycardia, enhance conductions through the conducting fibers across the AV node and so on. So it helps heart to regenerate itself if there is any kind of a block or a bradycardia. If the first dose of 0.5 milligram of atropine is ineffective, you can add a second dose of 1 milligram 1 to 2 minutes after the initial dose. Okay, you don't want the heart rate to go very down, or because it can be a problematic thing if the body is not perfused well, especially the brain. If atropine is effective and patient remains symptomatic, you can use temporary pacing. Now here you can also use adrenaline to extend, which is second drug of choice, but depends whether you want to go for that drug or you want to use temporary pacing that will help in recovering the heart from this condition. Atropine is definitely used for sinus bradycardia in first degree heart block if symptomatic, otherwise we leave it as it is. In type 2 second degree heart blocks and third degree heart blocks, which are kind of complete heart blocks or unpredictable heart blocks, we usually treat the underlying cause, and pacing activity might be required for this condition. So that's what I said. So atropine is not very much effective once the heart blocks gets in a very serious condition, basically second degree type 2 or third degree heart blocks. Atropine, since it causes tachycardia, it can worsen ischemia rarely, but there is another way of explaining explaining the same thing, so I'll come to it. So it can cause tachycardia, fibrillation, can worsen ischemia rarely. So it should be noted when you are giving it to any patient with any kind of ischemic problems of the heart, because it's tachycardia. So the organ perfusion and the demand ratio might alter, and that's why it can worsen ischemia. But it's also worthwhile noting that atropine is one of the most effective drug in acute myocardial infarction, as opposed to patients with primary conditions, primary conducting defect, as acute MI patients have heightened parasympathetic tone. So people with heart blocks and MI, atropine will work wonderfully as against those with any of the primary conduction defects, where you might need to either rectify the defect or need to pace the patient for the condition. So that's the second use of atropine in cases of bradycardia, sinus bradycardia, heart blocks. Atropine can work well as an anticholinergic drug, increasing the heart rate, increasing the conduction possibilities, and that's how helping in maintaining the perfusion. So if that is all about atropine and CVS, the next case is of a 43-year-old fat fertile female who is diagnosed to have cholelithiasis, and a decision is taken to do a cholecystectomy for her. Okay, so students who are new to medicine, cholelithiasis means gallbladder stones. So if a patient has gallbladder stones, you need to treat the emergency with the help of antibiotics, but once settled down, you need to do a cholecystectomy, that is, you need to remove the gallbladder from the patient's abdomen. So that's what is the normal thing that is done. She requires general anesthesia for the procedure because it's an operation. So anyway, you do it as an open operation, open abdominal operation, or you do it as a lap surgery, laparoscopic surgery. You require to have general anesthesia for the patient as per my knowledge, but I'm not an anesthetist, so less knowledge of that kind is available with me. Anyway, looking at a procedure, she is given glycopyrrolate as a medication before her anesthesia. What is glycopyrrolate? Glycopyrrolate is a substitute of atropine used as a pre-anesthetic medication. Very important thing, right? Glycopyrrolate does not cross the blood-brain barrier. It rapidly acts, is a potent anticholinergic drug, available as 0.1 to 0.3 milligram intramuscular injections. You can of course use atropine instead of glycopyrrolate. That's not a thing, but atropine use might lead to some other effects of atropine on the body. So if you want to just restrict the effects to pre-anesthetic medication, you require glycopyrrolate to be used. Glycopyrrolate is a drug which reduces bronchial and salivary secretions because it's an anticholinergic drug. It prevents vasovagal attacks and prevents laryngospasm. So that's how it helps the patient before the anesthesia, so that there is no aspiration of the secretions. Intubation becomes much more easy, respiration can be maintained at a proper pace, and that's how perfusion also can be maintained at a proper pace. So these all things are of help, but remember, these all things are anticholinergic activities. Now that's because of glycopyrrolate, which is a substitute of atropine, tailor-made drug out of atropine, I should say, not out of atropine, but like atropine, but with very specific action, selective action on the body. So it's one of the best known pre-anesthetic medication that can be given to the patient. So the case 4, now let's go to case 4. So here is a 5-year-old boy who is suffering from breathlessness, cough and wheeze with extensive rhinorrhea. Rhinorrhea is runny nose and presents to the casualty. Okay, he is also suffering from acute respiratory infection for the last 2 days. That's also occurring. So he's breathless, he has cough, he has wheeze, that is abnormal bronchial sound, maybe because of excess bronchial secretion, mucus secretion, bronchial narrowing, one of the important causes for wheeze to occur. Wheeze is kind of a musical note that is heard when the air actually gets out of the bronchi. So kind of a whistle blowing, which is most common with patients having bronchial problems. So he has rhinorrhea also, that's also important, that is runny nose, and he is suffering from acute respiratory infection. That might be acting as one of the most commonest trigger for a patient to get bronchial asthma attack. So he is a known case of bronchial asthma for the last 2 years. So this might be something of acute on chronic attack of bronchial asthma. So he is acutely suffering from condition, but he is a known case of bronchial asthma for the last 1 year and might be taking treatment also for that. He was nebulized Protropium bromide along with beta-2 agonist. Very important thing, Protropium bromide is an atropine substitute. It's an anticholinergic drug with preferential action on the tracheobronchial tree. So this is an atropine substitute which is used, which is called as Protropium bromide, and that has a preferential selective action on the tracheobronchial tree. Protropium bromide tackles the hyperactive parasympathetic tone in case of infections of respiratory tract. So whenever there is infection, patients with COPD, that is chronic obstructive pulmonary disease, their intrinsic parasympathetic tone is very high. So ipratropium bromide tackles that, since it is anticholinergic drug tailor-made for its effects on the tracheobronchial tree. Bronchial dilatation occurs, but it is less as compared to beta 2 agonist, so mostly used along with beta 2 agonist. It does not depress the mucociliary clearance, so that's important. So it will bring out all the secretions out of the body, out of the tracheobronchial tree, sorry. It has a higher efficacy as a prophylactic drug. It is a drug which can prevent, I should say, asthma. Anyway, it has also a role to play as far as acute management is concerned, but that is secondary. It's basically a high level prophylactic drug for maintenance of chronic asthma, and action starts within an hour and remains for 6 to 8 hours. So see, its action starts within an hour, so you cannot expect to get very quick relief as you get with beta 2 agonist like salbutamol with bronchial dilatation. So it cannot happen like that. But anyway, it is used in combination along with other drugs like beta 2 agonist in acute attack, but basically is meant for prophylactic purpose. Now here I should also mention that ipratropium bromide can also be of use for patients who have runny nose, excessive runny nose due to allergic rhinitis. So there you can use ipratropium bromide to dry up the secretions to an extent, I should say. We have one more agent that is called as tiotropium bromide, which has higher bronchial selectivity as compared to ipratropium bromide, and it's a long acting drug which acts almost for 24 hours. So ipratropium bromide, tiotropium bromide are anticholinergic substitutes of atropine, tailor-made for their actions on the tracheobronchial tree. Remember that whenever patient has COPD, whenever patient has a lot of secretions involved in the symptomatology, then you need to give the patients ipratropium bromide. Ipratropium bromide is one of the favorite, I should say, drug for any kind of respiratory issues in pediatric age group. So that's also important. It's basically given by nebulized route, and that's all about ipratropium bromide and atropine and tracheobronchial tree. Okay, the next case is about a 65-year-old man who presents with gradual loss of vision over the past 1 year. Okay, that's a very common scenario which a doctor will come across. A patient comes with gradual loss of vision. Most probably it might be cataract, anything can happen. There's gradual loss of vision. So anyway, whatever it might be, you need to check the eye from outside to the inside. So ophthalmologist wants to do a fundoscopy for this patient to see what's happening with the vitreous humor, with the retina, with the optic disc, and so on. So he wants to see it. So what is in between is the iris. So you want the iris and the pupils to get dilated so that you can see the interior of the eye, and for which he instills tropicamide eye drop 1%, so that it will cause mydriasis. Very important thing as far as ophthalmology practice is concerned, because without mydriasis a doctor cannot check what's inside the eye. So tropicamide is a atropine substitute. It's an anticholinergic drug, tailor-made drug for the eye. So it action starts within 20 minutes, lasts for around 5 hours. So it's one of the quickest and one of the best known mydriatic drug, and it's a substitute of atropine, because atropine is supposed to cause dilatation, but we'll come to it. So that's about tropicamide, which is an atropine substitute. But the story doesn't end here. We can use atropine 1% ointment, which is a potent mydriatic. But the problem here is that atropine will cause mydriasis, which is of long duration. So the person will be virtually blind for the next 3 to 7 days because the pupils will be dilated. So that's what is the issue. But atropine is used in pediatric practice and in certain other conditions. So not only in diagnostic, but as well as therapeutically. If a patient has a lot of problems with the iris, infection, inflammation of the iris, keratitis or choroiditis, you want to relax the muscles within the eye. So for that you require a sustained relaxation, for which you can use atropine. So it not only has a diagnostic value as far as mydriasis is concerned, but in some cases even pathologically curing certain conditions it can help in this way. So these are some of the therapeutic conditions in which you would like to use atropine as a mydriatic agent. As against that, the next drug in the line is cyclopentonate, which is available as eye drop, 0.5 to 1%, and is a potent, fast-acting mydriatic drug. It's also a good cyclophagic. You can use it in pediatric practice. Usually the action will come within an hour and will be lasting for another 24 hours. So that's about cyclopentonate. In fact, I see ophthalmologists interchanging between tropicamide and cyclopentonate. Of course, there are a few adrenergic drugs also which are of help, but I won't be covering them in this session. And the last drug which is anticholinergic for the eye is homatropine, which is less potent than atropine, and the effects last for around 3 days. So that's about drugs which are anticholinergic in nature, which are atropine substitutes or tailor-made drugs for eye, but which align themselves with atropine, used basically for diagnostic purpose as far as mydriasis is concerned, and also with therapeutic purpose with iritis, choroiditis and keratitis. Tropicamide is the fastest acting, followed by cyclopentonate, followed by homatropine, and atropine is one of the longest acting but is available as ointment, whereas others are available mostly as eye drops. So there goes atropine can cause atropine effects. Can again, contraindications for use of atropine is a narrow angle glaucoma, because you try to dilate the pupil, the iris will try to block the iridocorneal angle, and flow of aqueous humor might be interrupted. So that's one of the conditions in which you do not want to use atropine, that is narrow angle glaucoma. So something that comes to my mind when I am delivering these lectures. Okay, so that is about atropine. Now the next case. So here is a 10-year-old boy who has nausea and vomiting episodes whenever he travels by bus. So very common scenario. His symptoms are aggravated whenever he travels after taking his food. Definitely if he has food in the body, it tries to come out. It's a nightmare to have a patient or to have a person sitting next to you with this kind of a problem in a public transport. Okay, oh my god, what a scenario. Okay, the next is if the road is zigzag in its structure, then also he has this kind of aggravation of the symptoms. So whatever it might be, whenever there is motion, it causes him to vomit, so that's called as motion sickness. So this is nothing but motion sickness. His physician advised him to take a tablet before his journey. Around 20 to 30 minutes before his journey, he needs to take one tablet, but he complains that he cannot enjoy his trip and he feels drowsy. So that's one of the commonest thing that happens with this tablet. What is this tablet? This tablet is tablet hyoscine. That is, again, I should say, atropine like drug, but it crosses the blood-brain barrier, and once it crosses the blood-brain barrier, it depresses the vestibular excitation and gives symptomatic relief from nausea and vomitus. So motion, any kind of a motion, okay, let it be linear, zigzag, whatever it might be, it can lead to vestibular excitation. So hyoscine crosses the blood-brain barrier, reaches the vestibular and depresses the vestibular excitation. So that's how these drugs become important as far as their motion sickness is concerned. So these are some tracks. Even in fact, the hearing tract also has cholinergic pathways which are embedded within it. So those also are tackled if you take atropine. So that's one of the mechanisms, they say, a minor way, but that is also helpful in tackling with motion sickness. So remember that here this drug can cross the blood-brain barrier, so that's very important. That goes not in favor with atropine. Okay. The next case is of a 35-year-old man who experiences sudden onset of excruciating pain. That's important. Excruciating pain on the left side of the abdomen and the back. He is diagnosed to have a ureteric stone. That's very common. Usually, how you describe this pain? If you take out fish from the water, fish out of the water, it is in pain, and the kind of reaction you see of the fish turning in and around, so that is the kind of pain the patient experiences if he has a stone within the ureter. That too, a slightly bigger stone will cause a real nasty scenario for the patient as far as pain is concerned. So he requires relief, immediate relief from this pain. So to relieve his pain, he was given injection dicyclopine and a non-steroidal anti-inflammatory drug or a NSAID. Now, non-steroidal anti-inflammatory drugs would be drugs like diclofenac, ibuprofen, and so on. So those drugs, I should say. So he was given injection dicyclomine and NSAID. Dicyclomine is a tertiary amine which is a substitute of atropine. Again, atropine substitute. Why? Because it can cause direct smooth muscle relaxation and is used in abdominal colic. So there is a lot of constriction of the ureter which occurs, contraction of the ureter that occurs due to movement of the stone and the inflammation associated. So you dilate the smooth muscle, the pain will go off. One of the strategies to bring down the pain levels. Dicyclomine is used for almost all abdominal colic. So let it be of ureteric origin, let it be of GIT origin, let it be of pelvic origin, whatever it might be, you can use dicyclomine, even gynae origin to an extent. Okay, it is contraindicated in infants less than 6 months. That's important because it can give rise to atropine toxicities in children. It's available as injection, tablets, and liquid preparations. You have dicyclomine which goes along with paracetamol also. Now that's also very common. I think Colimix, I am not very sure, but Colimix has, I think brand name Colimix has dicyclomine, paracetamol, but check it. I am not very much sure about the combination that's there in this Colimix, but anyway, it's used extensively for colics of varied nature, and dicyclomine is an important drug as far as antispasmodic action of atropine is concerned. Again, atropine substitute, but with a lot of antispasmodic action. The importance is that dicyclomine or atropine in general also may not be of that much of help in relieving biliary colic. So there is a difference. For other colics it's fine, but with biliary colic, in fact, it will not cause that much of relaxation. So that's also needs to be remembered, that cautiously to be used or maybe not to be used in patients with biliary colics. Otherwise, it's okay. We have one more drug which is nowadays used extensively, and that is drotavari. Now this is the antispasmodic drug with no anticholinergic property. Okay, it's antispasmodic, but it's not fitting into that typical anticholinergic property. It blocks the phosphodiesterase 4 for relaxation of smooth muscles. So there is an enzyme called as phosphodiesterase. It blocks it, and therefore causes smooth muscles to smoothen out or to relax. Used again in abdominal colics of varied nature, gynae, surgery, whatever you want to use abdominal colic, you can use drotavari. It can lead to hypotension after injection and is available as 40 and 80 milligram tablets, and injectable forms of Protropium are also available. Okay, now we come to case 8. Here we have a 35-year-old lady who presents with burning sensation of urine and with feeling of urgency. She has urinary burning sensation. Since the external uretary meatus is very near to the vagina, especially females who are in the fertile age group and sexually active, those females are at of greater, I should say, risk of getting UTI. Again, urethra is straight as compared to that what is found in females, that is found in males, and is short in length also. So that also adds. So proximity, length, structure, everything adds, and that's why females get UTI more as compared to that of males. But anyway, that's another way of looking at it. But here is a lady who has presented burning sensation and feeling of urgency. She has also pain in lower abdomen. She only complains of passing tiny urine whenever the urge to urinate is actually very strong. So these all things go in favor of urinary tract infection. And to start with, her urine is also turbid in appearance. So it's very common to see this kind of a disease in females. In fact, she can suffer from fever, nausea, vomiting as additional symptom also. But the case is not meant for that. So what she is prescribed is a vasicoselective. So it's a bladder selective anticholinergic drug, tablet fluoxetine. It's available as 200 milligrams TDS. So it will cause relaxation of the urinary bladder. So we have 3 drugs in this list. We have fluoxetine, oxybutynin and tolterodine, which are available as oral tablets as well. I'm not sure if injectable tablets, injectable preparations are available, but these are atropine substitutes, tailor-made drugs for bladder, and which can cause retention, relaxation of the bladder, retention of urine inside them, and help in various conditions. So we use them for urinary tract infection and for other urinary urgency problems, like children who there is a problem with bedwetting at night, excessive bedwetting at night, or problems like UTI, any problem where this incontinence of urine, where urine is passing out. You just relax the bladder so that more urine remains inside it for a longer period of time and give these patients some relief out of their symptoms. So that is case number 8, which relates to atropine tailor-made drugs for bladder. If I am sure, and if what I remember is tolterodine is also enzyme inhibitor, so it will have that impact too when it is therapeutically given to the individual. So you need to look at the other drugs which are given along with this drug interaction, and which becomes specific for enzyme inhibitors. So that was case 8. I won't go into all the cases, but because since they are not that much of a use in clinical practice, or I have not at least come across them, are gastric acid inhibitors like pirenzepine, which is specific muscarinic 1 receptor inhibitor. We don't use these drugs nowadays because we have better available drugs like H2 blockers, Protropium inhibitors. We have few more other drugs like clinidium, which is also a gastric acid inhibitor drug. In obstetrics, we use valethamate, which dilates the cervix. So this is one of the drug, but we have better drugs available. So I don't think this drug is that much into use, but this is again anticholinergic drug which should dilate the cervix and help in dilatation and relaxation of the entire system, female reproductive tract. So these drugs help in that. And then the last, we have Parkinsonism. Parkinsonism is a neurological disorder because of imbalance of presence of dopamine within substantia nigra, and that what causes fine rolling movements of the hand, tremors, mask like face, rigidity, hypokinesia in individuals. So Parkinsonism, in Parkinsonism, it is one of the schools of thought in pathogenesis is imbalance in the cholinergic activity. So a few drugs which are anticholinergic in nature, like trihexyphenidyl, which is benzhexol, can be given in mild cases as monotherapy, and it's one of the drug of choice. Remember, it's one of the drug of choice for drug induced cases. Now that brings me to the last point: which drugs have anticholinergic activities. So drugs like tricyclic antidepressants have anticholinergic activity. Then we have antipsychotics, which also have anticholinergic properties. So these are few agents which I at least remember as of now, which are also having anticholinergic activities. So those can be an issue. A side effect profile of a drug will increase. So that is all for atropine and its substitutes. I hope you like this session. Thank you for watching. Please do subscribe to my channel. Your subscriptions do matter to me, because if I need to move, I need to have your subscriptions. It's a win-win situation between you and me. You get the required knowledge, I get the required subscriptions. Thank you, and since you are at the very end of the video, it would be great if you could push the like button, because that gives us a lot of motivation. Once again, thank you, good evening, bye.